Good afternoon, everyone. It's 12 o'clock for me, 1 and 11 o'clock for others probably. Thank you for calling in today. I'm Dr. Kathy McLaughlin, co-chair of the ACS National Roundtable on Cervical Cancer's Self-Collection Work Group, and I will serve today as the moderator. Welcome to the first of our three-part webinar series on self-collection, with today's session on landscape of self-collection testing. We're excited to share a foundational overview of HPV self-collection, including available testing options and current clinical guidelines. Before I begin, I need to address a few housekeeping items. Today's webinar will be recorded. The link to view the recording and a PDF of today's slides will be shared with all who have registered. And in addition, the recording link will be posted on our website in the next few days. If you have any issues during today's webinar, please use the chat. If you have any questions for the presenters, please use the Q&A. To ensure that there are no disruptions during the presentation, all participants have been muted by the host. To ensure that we have sufficient time for Q&A at the very end, we will be sharing full panelist bios in the chat. Our presenter today is Dr. Sarah Temkin. Dr. Temkin is the Senior Director of Early Detection of the American Cancer Society, a gynecologic oncologist with over 20 years of clinical and research experience. She's an expert in cancer prevention, screening, women's health, and health equity. You can read her full bio in the chat, but let's go ahead and get started, and we'll have even more time for questions. And welcome, Dr. Temkin.
Thank you so much for that introduction and for having me here today to talk a little bit about self-collection. The presentation objectives are here on the slide today, slide that's up on the screen. They are to understand the burden of cervical cancer in the United States, be familiar with current and proposed changes to screening guidelines, understand the impact of social drivers of health on uptake of cervical cancer screening, and thirdly, review the evidence and effective implementation strategies for HPV self-collection. The next slide. The topics are going to include a background on cervical cancer screening and the impact of social determinants of health, as well as some information about the who, what, where, when, why, and how of HPV self-collection, and also some tips on putting HPV self-collection testing into practice. The next slide. And then to just give a little bit of background, I'm going to start with the next slide that shows recent trends. It's 50 years of trends in cervical cancer incidence and mortality. And we've made so much progress here since cervical cancer screening was implemented in a widespread fashion in the 1950s. Both incidence and mortality have declined, making cervical cancer no longer a leading cause of death amongst women in the United States. Additionally, in 2006, a cancer prevention vaccine was made available in the United States, the HPV vaccine, which helps us towards making this disease preventable for everybody. However, as you can see from this graph, over the last 20 years, we've seen a decline in the slowing down in the declines in incidence and mortality of cervical cancer. In 2025, we're still expecting over 13,000 new cases of cervical cancer and over 4,000 deaths in this country. The next slide. One of the reasons that cervical cancer is a preventable disease is because of the natural history of the formation of cervical cancer. Nearly all cervical cancers are caused by one of several high-risk types of the HPV virus. Viral infection is very common, as we all know, and most people are exposed to the virus sometime in their late adolescence or early adulthood, and most people will clear the virus as well on their own without intervention. A small number of people, however, will develop precancerous changes that can be identified and treated before they become malignant. opening up the opportunity for cancer prevention. The next slide. We also know that overall, the American population is up to date with cervical cancer screening recommendations. This slide just shows the prevalence of up-to-date cervical cancer screening amongst women ages 21 to 65 between 1987 and 2021. And so we know that there are some differences in screening by race and ethnicity, which insufficiently explain disparities in mortality from cervical cancer, because Black women, for example, are just as likely to be screened for cervical cancer as white women, but have a mortality rate that's about 75% higher. And you'll also notice from this slide that following the pandemic, unlike other disease site screenings, cervical cancer screenings have not recovered to their pre-pandemic rates, and are lower than goals set by public health agencies. The next slide. There also are many health disparities which impact access and screening for cervical cancer. These are social determinants of health, which are the conditions in which we live, work, learn, play, worship, and age. And they include both individual factors and social and structural factors that that may or may not be within someone's control, such as policy factors, governmental factors, access to housing, and income and education. The next slide. And so as you can see from this slide, various social determinants of health or social factors are associated with being up to date or not up to date on cervical cancer screening. The people on this slide who are most likely to be up to date with cervical cancer screening include those with private insurance, higher incomes, more education, and private health insurance. And the next slide. Geography also can play a role. Oh no, my map on the right got messed up, but that's okay. On the right, you should be able to see that up-to-date screening varies by state of residence as well, and there are multiple individual and structural factors that influence these rates. Rates across states of being up to date with cervical cancer screening vary from 69 to 83%. And in safety net settings, which are the map that you can see, those stressors on individuals and systemic and exposure to systemic structures are greater, or barriers are greater, and rates tend to be lower in those settings. So as you can see from up-to-date screening rates in FQHC settings, these actually range significantly below the state averages. And the next slide. So despite cervical cancer being a preventable disease, the availability of effective screening and vaccination, over half of cervical cancer cases in the United States today are still diagnosed at a late stage. Of those individuals who are diagnosed with cervical cancer, ultimately half have never been screened, and another significant portion have been underscreened across their life. The next slide. So beyond access to screening and barriers to just getting that initial test, there are also barriers to the screening across the screening process. So if you can click through, actually, Courtney, there's a couple clicks there. Yeah, you'll see, we just talked about how 76%, almost 80% of individuals in the United States are up to date on their cervical cancer screening. But of those people who have an abnormal test, it's about half of them that receive timely colposcopy or a diagnostic test within 3 months. And then for those who go on to have a cancer diagnosis from screening, the median time to cancer treatment initiation is over 2 months. So there's substantial room for improvement across the entirety of the process to improve cancer outcomes. And the next slide. For this section, we're going to discuss a little bit about what the current guidelines are, and also how self-collection changes those guidelines. Since 2020, the American Cancer Society has recommended primary HPV testing as the preferred method of cervical cancer screening. There is some leeway in these guidelines for those people who are not very familiar with them for other methods of screening that include co-testing and cytology for those individuals or clinical settings where HPV screening as a primary modality is not available. And self-collection is new and FDA approved first in 2024, essentially as a method by which a patient does their own collection of an HPV test. If you could go to the next slide. There are some differences between the American Cancer Society guidelines for cervical cancer screening and those recommendations made by other organizations. Both the American College of Obstetricians and Gynecologists and the U.S. Preventative Services Task Force recommend screening starting at age 21 and screening with cytology to up till age 30. And there are some changes expected to the U.S. Preventative Services Task Force guidelines, which will, we hope, include guidance for self-collection. But for the 30 to 65-year-old, I think the guidelines are pretty consistent about the recommendation that primary HPV testing is a acceptable, if not preferred, modality for cervical cancer screening. The next slide. What does the evidence show about this? There has been a lot of evidence comparing test characteristics between self-collected and clinician-collected HPV testing. And I think from 3 meta-analyses, I think we can feel comfortable saying that the sensitivity or test characteristics of self-collected HPV are good enough to make this test useful. The self-collected HPV is better at detecting high-grade dysplasia than cytology alone in the first round of screening, and has comparable sensitivity and high agreement with clinician-collected samples. The next slide. There are several tests that are FDA approved for primary HPV testing. The self-collection kits that are available in a healthcare setting include those tests listed here. And additionally, this year, a device for home collection has been approved, which is going to be made available only in select geographic areas, is my understanding to date. The next slide. Self-collection is relatively straightforward for people to do. I think we all became very familiar during COVID with using a Q-tip to collect a biologic specimen and send it to a lab or do it at home even. And so there are very good instructions that are available for patients. Otherwise, this is really quite, I think, straightforward. The next slide. In terms of acceptability to patients, I think there has been high acceptability shown to vaginal diagnostics across multiple settings, not just for HPV testing, but also for other specimens such as STI collection. The in general, patients find self-collection to be easy to perform and have other benefits such as less embarrassment, less discomfort than a clinician-collected specimen, and that they can be afforded privacy that's not available during a clinician-collected test. There is, of course, a potential harm in that without a clinical exam, there is the potential to miss a physical exam finding for which a patient does not have symptoms. The next slide. So in terms of eligibility, I think this is pretty clear that this is an HPV test. The American Cancer Society, as we already mentioned, has been recommending primary HPV testing for a number of years. And so patients must first and foremost be eligible for primary HPV testing. Patients who are still recommended to have a clinician collected screening test include those patients who have a preference for this, patients who really have a tricky clinical exam, such as those who have HIV or other immunosuppression, may have had an in utero DES exposure or have reported symptoms that require a clinician collected exam anyway. There is another consideration. This is mainly an insurance consideration for patients under 30 or those with primary Medicare coverage. There may be limitations on primary HPV testing for those individuals, and that should be clarified before the patient undergoes a self-collected test, cancer screen. The next slide. So additionally, the self-collection will change and can change where cervical cancer screening is performed. For clinician-collected tests, these need to be performed in a traditional healthcare setting with a healthcare professional who's trained to do a pelvic exam and requires a lot of specialized equipment, such as a table with stirrups and speculums. With self-collection, this really changes. Any healthcare professional can oversee the testing and the results. So this essentially can be used as part of any appointment, laboratory visit, or radiology visit, as long as there's a private setting that can be used by the patient. And of course, the telehealth device has been approved to be used in home collection as well. The next slide. But there are some things that change about follow-up with self-collection. The next slide. First of all, for those patients who are HPV negative on home collected, if it's a clinician collected test, that patient can follow up in 5 years. But with self-collection, we're now recommending 3 years of follow-up. For patients who have a high-risk HPV type, if the sample is clinician collected, there can be reflex cytology performed, but those patients are now going to be recommended to go straight to colposcopy. So there may be an increase in the number of colposcopies performed, depending on the population prevalence of high-risk HPV. In the high-risk HPV or other HPV types, HPV 16, 18, or other HPV 16 or 18 negative, but other high-risk HPV positive group, again, because reflex testing will not be available, that person is going to need to return to a clinical setting for a clinician-collected specimen. So the next slide. Just to sort of summarize, what this means for people. These are some differences. Obviously, a clinician-collected sample is collected by the clinician. The self-collected sample is collected by the patient. And other than that, you can see from this table that much is similar about what test is done and what to do with a positive result. And I'll just make note of that both tests are considered to be more accurate than a cytologic test alone. The next slide. So for the last portion of this section of the webinar, I'm going to talk a little bit about how to put HPV self-collection testing into practice. And the next slide. There are a few major points to consider when talking to patients about self-collection. They are about 1 in 10 patients are going to receive a positive test. And again, this is of course going to depend on the patient population within the clinical setting. If a patient receives a positive test result, if it's HPV 16 or 18, they will require a colposcopy, and that will require a clinician exam and a speculum and everything that goes with that. And then even if the patient has an abnormal HPV, but it's not HPV 16 or 18, the patient will still need will still be recommended to have a clinician collected exam so that additional testing can be performed. And they will need more closer follow-up as well. The next slide. So just for consideration, all of these tests are going to use the same PCR assay to detect the same 14 HPV types and should provide results that include 16 and 18 genotyping. So the first step in implementing HPV self-collection in a clinical setting is going to make sure that the setting can offer primary HPV testing. This requires buy-in with the lab, and there are manufacturer-based instructions for use as well. The next slide. Insurance coverage for HPV self-collection tests, of course, is important. Primary HPV testing is part of the U.S. Preventative Services Task Force recommendations for patients age 30 to 65. CPT codes already exist for patients receiving primary HPV testing. And so how the sample is collected is not expected to change in the billing code. The same is true for the same ICD-10 code is used for cervical cancer screening testing. The next slide. So I think a last important consideration is the follow-up pathway after an abnormal test. With self-collection, there is expected to be more abnormal screen tests that might be identified. And so the referral patterns or patterns of care within the system may change. There may be more clinician collected and colposcopic appointments that are referrals that are needed. And hopefully there should not be a change in the number of excisional procedures or cancers identified. But the point and the goal of all of this is still to improve cancer outcomes, have fewer cancer cases, and have those cancers that are detected be detected earlier when treatment is more feasible. The next slide. There are some IT and EHR considerations in terms of making sure that there's an order for self-collection, that the CPT codes are not, and ICD-10 codes are still should be transferable, but then screening intervals and prompts for appropriate interval dates may need to be adjusted as well. The next slide. And some key takeaways from this presentation are that we know that social determinants of health influence cervical cancer screening, not just from the initial screen, but also throughout the screening process. HPV self-collection is a new option for screening that may be advantageous to certain patients, especially those with limited mobility, who are anxious about a pelvic exam for a variety of different reasons. HPV self-collection, we are still recommending that this be repeated after 3 years, even 3 years after a negative test. For patients with a positive HPV test, this may change the referral and follow-up pathways, or it's expected to. But essentially, HPV self-collection is primary HPV testing, and hopefully will be another tool to improve cervical cancer outcomes and reduce the burden of this disease in our population. The next slide. And then lastly, this is a few resources that I think will go into the chat that folks may want to take a look at. And then the next slide is opening this up for questions. And so I think my panelists or co-panelists are going to come back.
Yeah, thank you. Thank you, Dr. Timken, for that review. Just a reminder, if you do have questions, please put them in the Q&A box. So now we're going to move into a discussion phase of the webinar, and we will base that on questions that you've submitted. To help Dr. Timken address a few of these questions, I'd like to welcome Dr. Robert Smith, Senior Director of Guidelines Development at the American Cancer Society. You can find his full bio in the document shared at the top of the call. Bob and Sarah, thank you so much for being here. I've been monitoring the Q&A box, and questions are continuing to pour in, but I'm going to try to kind of theme them a bit, but just based on what's out there, I think one of the themes and questions relates to, why this emphasis on or shift toward favoring HPV-based screening over PAP.
I'll go. It's much more accurate. We actually, and when you want to widen the screening interval, what we find is that when we screen women with cytology alone, there's a much greater likelihood that they will be diagnosed with an advanced lesion on the next time they're screened compared with women who've been tested with HPV. Over many, many years, our screening guidelines for cervical cancer have evolved. We've started later. We've widened the screening interval. Testing has been more accurate, but the main difference is our growing recognition that it's an active HPV infection that is required for a woman to develop cervical cancer. It's not sufficient, but it's required. And so when we test for HPV, we are testing for the principal underlying cause of cervical cancer, and an active infection means that we need to bring all of our apparatus to try to understand, what's going on with that infection and work these women up and address it. So it's just a much more accurate way to screen, and it also allows women to go a wider interval between screening, provided that this is what their doctor is recommending.
Thank you. There's several questions on coding, billing, coverage, those type of questions. If you don't mind, I'm going to start that answer related to coding specifically to let folks know that there is a specific new CPT code as of January of this year. It is 87626, and this is specifically for HPV tests that report pooled results and individual genotyping, whether that's partial or expanded. So this test code applies to BD Clarity, Roche, and Abbott lab platforms, and this applies to their primary HPV testing, whether that's by clinician or self-collection, as those three lab platforms now all have approval for both clinician and self-collection. And that code also applies to the HPV component of their co-testing. It is 87626. And again, that was of January of this year. And so it's not a change that just impacts self-collection, it impacts the HPV testing for primary or co-testing with those particular lab platforms. Bob and Sarah, I don't know if you want to add more to that piece.
I think that we've been saying this, and I think like self-collection should be treated the same as primary HPV testing, for most billing and coding purposes.
Yeah, we hope it will be, but what we have found, I agree completely with Sarah, and if any insurance company asked me, I'd say it's an HPV test. Of course, it has to be covered. But we have seen, for example, a new version of a stool DNA test for colorectal cancer, a multi-target stool DNA test for colorectal cancer, that health plans are saying we don't have to cover that because it's new, even though it's essentially the very same test that has already been recommended both by the ACS and the Preventive Services Task Force. So I think women should not be surprised if they find that there's a coverage issue, but they should push back that if there's every reason that this test should be covered.
And I would, I guess, like to respectfully encourage folks that coverage has not been an issue in the systems that have implemented this. So this test has been more broadly implemented in Washington State because a lot of the research has come out of the University of Washington in partnership with Kaiser. And they have now partnered with some groups at the University of Minnesota, and we've implemented this across Mayo Midwest. And what we found is there's no issues with private insurers covering. And with Medicaid, it's really state dependent. So we've been able to confirm coverage. Folks should be aware that a HEDIS update last year included a statement supporting coverage of member collected samples. And we're going to drop that link in the chat. And as well, in terms of UDS and HRSA, there's a proposal out there right now that is closing to public comment at end of day tomorrow, supporting self-collection and supporting coverage of the screening continuum. So supporting the folks who have to come back for diagnostic testing and colposcopy. And so we're going to share that link as well, and would encourage you to check out that proposal. And if you feel so moved and comfortable, there's still an opportunity to provide emails with statements of support for that, which could make a huge difference for this audience and clinics and networks who are calling in today. It is 87626 for CPT. Some of the questions have to do with management and how the algorithm does or doesn't vary. And I think Dr. Timken had, described the results management of the self-collection, which you can use the ASCCP app. Primary HPV is built into that, and they are going to be updating for self-collect. But you do still need to consider past results. It's still risk-based management. For Bob and Sarah, one of the questions evolved around HPV sample accuracy versus cervical sample accuracy. A little more questioning toward the evidence base for that comparator if we consider the cervical the gold standard.
I'll take this. So far, the data show that the collection for HPV specimens is very, very similar. In fact, it's so close, it's hardly worth calling it a difference. The one thing that I think people would say, though, is that if a woman has a positive test and there needs to be cytology, that the clinician is going to collect that specimen from the cervix as opposed to from the wall of the vagina. But women should not feel that they are getting an inferior specimen collection if they're engaged in self-collection. I mean, Sarah, would you agree?
Yeah, I totally agree with that. And I want to make the point from this and the last question also that like a negative test is similarly negative, right? Like it's not a question of the test being, the positives being reliable and the negatives being differently reliable. The both positive and negative are accurate regardless of whether they're self-collected or clinician collected.
Thank you. Some folks are seeking clarification around the FDA approvals for healthcare setting or clinic-based use versus home collection.
So the only home collection that has been FDA approved is the teal wand, and I see in the chat that this is available in more states now, and more states are expected. So I think this is changing in pretty real time, where the teal wand is available. But the other self-collection kits have been FDA approved for clinician collected or in clinic collection. And I think that the application of that can be taken pretty broadly. Like if people have space in their clinics that's even a bathroom, I think most people are pretty comfortable with the idea of a swab, a self swab in today's day and age. So as long as there's a sort of private area available, this can be made available in very, I think we can be creative about the clinical settings that this is used in.
Yeah, I'll just add to that. It's probably really important for women to appreciate, at least where that option is involved, but perhaps even with the teal specimen, that we're not, self-collection does not involve the same kind of collection that they're used to when they go to the doctor, which might be kind of off-putting the prospect of how would I do that. And in fact, you're talking about collecting a very simple specimen from the inside of the vaginal wall. And it's probably going to be the case that it won't be too long before other kits are going to be approved for home testing once a large study that's underway through the NCI produces results and gives the FDA more confidence about a range of tests that could be used at home. So I'm sure that the clinic setting will remain an option for women who would find that more comfortable or reassuring, but I think we are going to get more options for self-testing at home.
Thank you. Someone asked about approximate percentage of positive results for HPV 16-18. I'd like to take that one. I have a pictorial that I use in lectures that I got from other members of the self-collection work group, and obviously prevalence can vary depending on population, but what they generally say in terms of shared decision-making and counseling toward this option is that about 90% of folks will test negative and then would need the repeat in 3 years, assuming they'd had no prior results or had past negative results. About 7% will have high risk other and need to come back for that PAP to guide management. And so it's important when people are being offered this option and counseled on it that they're aware of that possibility. And about 3% will test positive for HPV 16-18 and need to be referred directly for colposcopy. All right. Oh my gosh, so many good questions. Just scrolling through here. Let's see. Sorry, there's so many questions and we've answered some of them, but not all. Let's see. Someone had questions about the rate of rejected lab samples. And I don't know if that was kind of in context of comparing like an unsatisfactory PAP from a clinician cervical collection versus it is possible to get an invalid result. I don't know if either of you want to comment on that. I mean, I think it's better to have an invalid result than a false negative. And so there's controls in the lab platforms, from my understanding, that if you don't have an adequate amount of specimen from the self-collection, which would rarely happen. We've had it happen once in the 430 people we've screened so far in our system since implementing, so pretty rare. I don't know, Sarah and Bob, if you've seen reports on that, invalid percentages.
It was a much bigger problem in the past than it is today. And what I think we've seen is that the labs have become increasingly conditioned over the years to not just go ahead and read an inadequate specimen. I mean, it's especially when there's no endocervical cells. I mean, the report, and if a report comes back that says there's no endocervical cells, it should be very clear that the test does need to be repeated. But I think the thin prep and the modern approaches now make that rather uncommon.
Absolutely. Somebody had a question about thin prep media, and do these new collection options mean that that's going away? And no, the brush sample is swished or smashed or twirled or whatever word you want to use into that thin prep whether that's with the provider in the healthcare setting immediately after collection or with drive transport to lab, the lab techs are doing that. So the thin prep medium, in my understanding, is not going away.
And there still will be a need for cytology. I mean, self-collection doesn't remove
Right.
the need for cytology completely, right? For people who have a positive HPV that's not 16 or 18, they're going to need a clinician's sample anyway. And then there are a number of people who are either going to prefer a clinician collected specimen, or they have some other gynecologic problem that they're having an exam for anyway, and then they have can have their specimen collected at the same time. So it's not, I don't think this move means that there will never be a need for cytology again.
No, in fact, I'll just add to that. When you consider the number of women who fall off regular screening, there's a lot of women who would need cytology if we had higher rates of regular screening. So the need for cytology in the labs and qualified people to do it is not going to go away. And the cytologist in this instance plays an important role because they read a lot. We used to see these studies where in these small settings, the cytopathologist, the cytologist was a more accurate reader than the cytopathologist because of the high volume, of doing it. Kind of always bothered the cytopathologist, but it's true.
Someone commented about Quest Lab in their area utilizing self-collection in the office only, and yes, that's true. So again, Roche, BD, Clarity, and Abbott, those are approved for healthcare system or clinic, type setting collection, and so they're following the rules with that. There are some questions about the enduring guidelines recommendations for 3-year intervals and the draft recommendations from USPSTF for 5-year intervals. I don't think any of us are privy to when those might be finalized. That was one of the questions in the chat as well. But I know as a primary care clinician, that can be incredibly discouraging and frustrating to have the guideline groups not be in alignment or concordance. It makes it more challenging for us. And I think, most clinics are following in terms of like UDS and HEDIS reporting, USPSTF. So I don't know from an ACS standpoint if you could comment to that potential disagreement in intervals and maybe reasoning behind that, or upcoming things to watch for from other guideline groups.
Yeah, well, I would just emphasize that the task force's guidelines are draft, and more often than not, the draft guidelines become the final guidelines, but there are exceptions. There are times when people have written in and made a case for a different recommendation, and the task force has reconsidered and made that, change the draft. The enduring guidelines simply set 3 years as a condition of waiting for the available data from the trials and wanting to see evidence of what happens with these durations, shorter or longer, in self-collection. There's other factors that may come to bear eventually as we learn more about self-collection that would either leave this early 3-year recommendation in place, or decide that it could be widened to 5 years because it was safe, and it would also have the advantage of being consistent. Where there's had been a very large difference between the task force and the American Cancer Society, each of their most recent updates is the age to start screening at 21 or 25. But both organizations have a record of telegraphing what they think likely will be happening once FDA makes a decision about new directions in cervical cancer screening. And they've been pretty consistent in that respect, especially in terms of prioritizing HPV alone testing.
One of the questions is there a definition of healthcare or clinical setting for administering the self-swab, or is it a little more open to interpretation?
Wait, can you say that again?
So with the Roche, BD, and Abbott FDA approvals using language of healthcare setting, how may we interpret that more broadly, less broadly?
I think it's a good question. It's certainly it hasn't troubled anybody until somebody comes up with calling something a healthcare setting that by most normal definitions wouldn't
Right,
mean it. There was
right.
some question as to whether telehealth can be treated as a healthcare setting. I kind of don't see how, frankly, but perhaps it can be. I mean, I'm not sure what constitutes supervision in that context if you're at home and you're having a video conference. I'm not
Mhm.
sure I've heard that that's counts, but we could be surprised. I think most instances, though, it's the idea is that somewhere, like Sarah was saying, somewhere in a doctor's office, this is very easily to do, either in in the examination room, in a bathroom, someplace where some privacy is assured, and that really does open the door to the potential for broader testing for women who are no longer seeing a gynecologist and have a primary care physician who's alert to an opportunity for testing when they may have not been screened for cervical cancer for several years. There's also the challenge of having a record of normal test results before the age of 65. It's a very, very small fraction of women reach the age of 65 with that record of consecutive normal examinations, and they reach a point where it becomes much more difficult and the testing is less accurate, that would allow them to stop.
All right. I wish we could continue. We have so many great questions. Thank you, panelists and attendees. Many of the questions that we didn't get to today will be answered in upcoming webinars in the series. So please, we hope you can join us for those. Britta will drop the link in the chat. There will be a recording of this call available on the Roundtable website in the next few days. And lastly, if you could please take a moment to complete a brief evaluation of the session, we'd really appreciate that. That will automatically pop up when we end the seminar, but we do intend to keep the questions that you have shared with us today, bring those back to our HPV self-collection work group and divvy up the work of answering those, and intend to send that to registrants. And correct me, ACS folks behind the scene if I'm wrong, but I believe that's the plan. So we will really try to get the answers to you if we weren't able to speak to it today. So thanks again. Have a good afternoon.